Okay, this is the Overactive Brain, episode 2. So you're a newbie with me.
Yep.
I'm joined by Alessandrina Element, my girlfriend, who is sometimes unfortunate to be party to my little experiments.
Sometimes?
Sometimes, yeah. But we've come together today to talk about your work, what you do for a living, and to sort of explore the whole subject of mental health to some degree and what your involvement has been in it since you started working for undisclosed company name around how long ago?
Close on 3 years ago now.
About 3 years ago.
Yeah.
Because you're working for a company now that you've been with for at least 18 months, is that right?
Roughly, yeah.
Almost 18 months.
Yeah.
But talk to me about what you do at the moment, your job role, and what that entails. So what are you doing at the moment in terms of your...
It's a little bit of a multifaceted role. So my main role is as an independent mental health advocate. So that's basically about people who are detained under the Mental Health Act. So they pose a big risk to themselves or to others because of their mental health. So they get detained in a mental health hospital. You get a lot of your rights taken away from you. So an IMHA, Independent Mental Health Advocate, is there to advocate for them because they perhaps might struggle to speak up for themselves. They might not know what their rights are while they're in hospital, detained. And just to be support for them, really. I also do now what's called a relevant person's representative, which is another role which is for people who have been assessed to lack capacity for some reason. So they might be in like a care home or some sort of like residential type home because they have dementia.
Lack capacity?
Yeah, so that's quite a big subject on its own because people use that a lot, but capacity is issue specific. So you can't just say someone lacks capacity, but you can't really just use it as a general term. So they have to have been assessed to lack capacity in a specific area.
But what does lack capacity mean? What's the interpretation of capacity?
They can't make choices for themselves. So if someone's been assessed as lacking capacity over their finances, they can't manage their finances on their own for whatever reason that might be. They're going off and spending it. They're forgetting what they've spent. They're making unwise decisions.
So it's a deficiency within a computational perspective in terms of their mental health. So it's not necessarily a physical capacity; it's a mental capacity.
Yeah, pretty much. So it could be capacity over if they can decide where they live. Are they choosing the right places for them to live? Hence why they might be kept in a care home. They might have lost capacity about, like I said, their finances, taking care of themselves on a general day-to-day basis. So basically what an RPR does is goes to see them when they're under a DOLS, which is deprivation of liberty safeguards, which again, someone's had their liberty taken away from them. They're not free anymore. They have to stay in that particular... And
is that only under the Mental Health Act that can be taken away?
That's not under the Mental Health Act. So DOLS is the mental... it's to do with capacity, so it's the Mental Capacity Act. So it's a slightly separate role. But the two acts do sort of link up together, but the Mental Health Act will always trump the Mental Capacity Act. But yeah, so a DOLS, deprivation of liberty or safeguards. So if someone's having their liberty taken away from them, you have to have safeguards in place because otherwise, unfortunately, in some places people will just bung someone in a room and sort of lock them in there, strap them in their bed and leave them to it. So you've got to have some sort of safeguards in place to make sure that they are still being treated like human beings, that their care is still personal. So say if Bethel, who's 90, who's got dementia, is in a care home, you can still treat her well by feeding her, making sure she's bathed and you know, this, that and the other, but that just makes her a number, basically. So she's still got to be personable. So if she's a devout Christian, maybe there needs to be a condition written into the dolls that she goes to church once a week. If she loves going swimming, maybe she goes swimming once a month. If she's obsessed with Elvis Presley, maybe it's that she's got loads of pictures of Elvis Presley in her bedroom, or, you know, just
to make it as unclinical as possible.
Yeah, basically. Yeah.
Real life.
Yeah.
I guess as much as they can do in a clinical setting, I suppose.
Yeah. So an RPR goes in, relevant person's representative, and makes sure that the managing authority, the care home or whatever, is sticking to the conditions of the dolls and is just basically giving them a good sort of quality of life and not just sort of keeping them alive, basically. So that's another thing that I do. And I also do community advocacy, which is basically people who are not in a hospital setting, not in a care home, not in any of that. They're just out in the community like you or me, but they still have a mental health issue and they just need someone to advocate for them in regards to a specific issue. So maybe they think that their mental health team that they go and see once a month just isn't listening to them. Maybe they want their medication changed and they're refusing it for some reason, or just anything like that, really. Just they can't voice for themselves. We're about empowering people to have their own voice. It's an empowerment service. So we're not there to do it for them. It's not a support worker. We are there to empower them.
That's quite important, isn't it, from the different courses that I've taken in terms of mental health. The empowerment is quite an important aspect of it, which is that we want to give people the capacity to do it themselves. Yeah. Essentially, become responsible. Take as much responsibility as possible, whilst being mindful of important decisions that can have ramifications.
A lot of these people, unfortunately, that you come across in mental health hospitals are revolving door patients. So you might see them in the hospital and then they get discharged, and then a few months later they're back again, and they're known throughout the system, be that mental health hospitals, community mental health services, hospitals, police, GPs. They're very well known because they are just revolving door patients. And in that scenario, they become institutionalised and they really end up relying on services. And especially if they've got something like a personality disorder or maybe something like autism, then they can latch on to services and find it really difficult actually to just be able to do things on their own. They become really reliant on services. So we're sort of the people who might come in and say, well, do you think maybe that you could actually... It's about challenging them because, if you have everything done for you all the time, then you do start to lose that kind of confidence.
Is there a fine line between the people who come and go, so those who are there 1 minute and they're gone and then they're back a few months later? Is there a situation where there is a real need for them to be making return visits to the hospitals and care units that these people are in, where it's not necessarily evidence of them becoming institutionalised? Or is it really they should come in, spend as long as they need to go through their treatment, then they're essentially put back into society, into normal society, with obviously the hope that they're not going to be making any return visits. But other people, I think my question is, are the people that are making return visits the ones who are vulnerable to institutionalisation, and they're not usually coming back because of any new issue? It is just purely the fact that they are becoming institutionalised?
I wouldn't say that's the main bulk of it. I'd say the main bulk of it is where people get a lot better once they've been in hospital and they come out of hospital and they're on the right medications, they're getting the right help, they're looking at the right stuff. Unfortunately, with a lot of people, once you get to that place of feeling really, really well, you think, maybe I don't need to take my medication anymore, or maybe I don't need to go to those therapy sessions anymore. And so you become complacent. And it's the same with a lot of stuff. If you think of like losing weight, if someone decides that they want to get really healthy and eat well and do loads of exercise, a lot of the time, once you've been doing that for a period of time and you perhaps reach your goal or you lose a lot of weight, you do perhaps start to become complacent and think, oh, that bit of chocolate won't matter, or, you know, that extra whatever won't matter.
Comfortable.
Yeah.
More confident.
And people who perhaps have some mental health issues or diagnosis, a lot of the time, one of the sort of common things that you might see is actually that they don't think that they're unwell. It's very difficult for them to recognise the symptoms of their illness when they are the person, you know, they're not experiencing it from the outside. And so a lot of people who might have these diagnoses actually don't think that they should be on medication. They don't think there's anything wrong with them. When they get brought into hospital, they don't think they need to be in hospital. So once they get out of that setting and go back home, it's kind of almost as if they think, well, I don't need to do it anymore. So they might stop taking their medication or stop doing this, that and the other. And unfortunately become unwell again and end up back in hospital. And you'd be surprised sort of how many times you can sort of go round that circuit and not sort of clock what's going on.
Yeah, so once these people do leave the... they're not necessarily leaving your care, they're leaving the care of the hospital that they're in, and you're a part of the system, you're a part of the programme, you're there as a representative to them, but are you an only representative whilst they are in hospital? When they leave and they are vulnerable to becoming complacent and gaining confidence and trying new things, which is where they're probably at risk of developing or redeveloping the conditions they had before, who's there to prevent that from happening? So who takes over from you when they are allowed back to society, if you like?
Well, the first thing to say is that we're technically not really a part of the system because I'm not employed by the NHS or any of these private hospitals. We are a completely separate entity.
You're a part of the supporting spectrum.
Yeah. We're commissioned by local authorities, by the government, but they can't instruct us, so we are completely independent, which is why it works so well. So when someone is discharged from hospital, like I said, we do the community advocacy. So if they are under a mental health team or have some sort of issue, then yes, we can still help them. But we're not there to... Our role specifically is not to help them cope with coming out of hospital. That's not what we're there for. We're issue specific. So if they were to come out of hospital and say, I really don't like the medication that I'm on. I feel like when I was in hospital that the doctors were just forcing me to take it, because if you're detained under the Mental Health Act, you can be forced to take medication orally or injected, which is obviously not very nice, but that's what happens. If they say, look, I don't want to take it anymore, I want to talk to my GP or, you know, my mental health team and talk about coming off it or trying a different medication or whatever, then we would support them just to speak to those professionals. And I think what a lot of professionals struggle with understanding about my role is that even if someone wants to make what we might deem as an unwise decision, so say if we have Tim, who's been in hospital numerous times, and we're going around this circuit where he's discharged from hospital, he stops taking his medication, he gets very unwell, he gets brought back into hospital, and we just keep going around in that circle. If he's discharged from hospital and he comes to us and says, I'd like your support in talking to my GP or whoever about stopping my medication because I don't think I need it, it's not my role to say, yeah, well, Tim, you really do need it because do you remember what's happened all the other times? I mean, we can talk through him and say, do you think that's a good idea? Because, you know, this is what's happened before. But at the end of the day, I'm not medically trained. It's not my it's not my job to tell him what he should and shouldn't be doing.
That must be difficult.
It is, because then you go to the professionals and you say, hey, look, Tim would really like to stop taking his medication. Do you mind if we set up a meeting for us all to sit down and talk about it? And they'll look at you as a professional and say, why would you do that? You know, it's quite obvious that when Tim stops taking his medication, that's what leads him back in hospital. But it's not It's not about what I think is best for him. It's about what he thinks is best for him. Because unfortunately, when someone has a mental health problem or a capacity issue or etc., people have the tendency to just say, well, he doesn't know what's best for him, so we'll just take that decision away from him without even involving him in the discussion about it. And that's why advocacy really was set up, is that professionals were just making decisions based on what's easiest for them or what they think is best without involving the person who the decision is actually about. You should still have a say in it's your care, it's your life. You should still have a say. And at the end of the day, if they've listened to everything you've got to say, they've deemed that you don't have capacity to decide in that situation, or they just think that you're making a really unwise decision, then, you know, perhaps you can sit down and talk about, is there a middle ground? Can you come to some sort of agreement? It's not just about taking their power away from them and overruling them just because you're the professional in the situation.
I suppose what it makes me think up is that you want them to make the decision that causes them to make a mistake. You don't want to be the one who makes that mistake. And I suppose that is what empowerment is if every decision that needs to be made on their behalf is made by somebody else, then, you know, the mistakes that are made, the person who is being treated, you know, has no responsibility in that at all. And I suppose even the good decisions, they don't get a sense of what, you know, the good decisions that they're making, they don't get a sense of achievement or success in making good decisions as well.
Yeah.
And
I think people just don't. People have lost the art of listening to people. So, you know, if someone's coming out of hospital and they're homeless and they've got nowhere to go and they're rehoused in some sort of supported living or something like that, and they say, I don't want to be put in the middle of a busy city because it freaks me out, it's too busy, I hate being in city, I want to be moved somewhere in the countryside. If they just go, it's just he can't pick and choose where he wants to live, he can just have whatever's available, you know, there's that sort of attitude, and then lo and behold he gets stuck in a place in the middle of the city and he freaks out because he told you he didn't want to live there and he hates it and he freaks out and he ends up back in hospital, and it's kind of just, they are telling you these things, but a lot of the time people just think they're being difficult, or you hear a lot of stuff like, that's just them with their personality disorder, you know, people with personality disorders are just really difficult, and you just hear that kind of stuff and you think...
Are these medically trained people the ones who are being quite objectional to these requests?
Yeah, sometimes.
Or does it tend to be people that are less medically trained, or...
You get a variety.
Because if you understood the client and their condition, and they said, I feel very claustrophobic, or I don't like cities, I don't like noise, so somebody with autism may not want to live near a busy traffic system for obvious reasons, and I think anybody who understands autism would know that them requesting that, if it took them to request it and it wasn't already been taken into consideration, that they should surely know that. So the people that are less sympathetic with regards to the request that they make, they need to make an educated decision as to whether there is some merit, or there is some... I think there's a fine line between some requests may be considered unnecessary, so there is no evidence that your request has anything to do with it flaring up your condition, etc. But there will be some instances where, yes, there's significant clinical evidence that would flare them up.
Yeah.
So I suppose that's all the part of the listening part, is you need to listen to what they're saying rather than just dismissing all of their demands.
Absolutely.
As being selfish.
It's really, really difficult. I mean, everyone knows how stretched the NHS is. I see it a lot when I go on to certain hospital wards. You can tell that the services are stretched and understaffed, and they haven't got time anymore to sit down with patients and get to know them, unfortunately. And a lot of the staff are perhaps agency staff who are just there covering for a couple of days a week or whatever. It's just there's no... Yeah, they just don't have the time to get to know people anymore, and it's just kind of a revolving door of people, you know. They just want to get them in, get them as well as possible, get them out, and just hope that they don't sort of come back again. So it is really difficult for them to get to know people and find out what is a reasonable demand and what isn't. And then for people who perhaps have a history of... you know, things like personality disorder is well known for having some difficult traits to work with. But it's important that you still try and spend the time to figure out who a person actually is, rather than just dismissing difficult behaviours and things that they say as their diagnosis, or as, oh, they're just like that, you know. Because everyone's an individual, and you can't just sort of dismiss them based on a diagnosis.
Is it quite a new concept, this advocacy work?
No,
I think I did come across advocacy with one of the courses that I was doing. When I say it's new, it's not something that's been around for centuries. I think
as a concept it is.
Yeah.
In hospitals and things like that, so it's now a statutory service. Maybe
that's what I'm talking about.
That
maybe
might be what you're talking about.
It's been written into the law.
I can't tell you the date as when that happened, but it's in terms of time, it's fairly recent. So before that, it wasn't a statutory service, and the people that I work for now are like what we call old school advocates, and they were around when it wasn't statutory. So basically, if the staff didn't want to let you on the ward, then you had no right to come onto the ward and speak to people. You had no power or sort of respect whatsoever. Whereas now it is a statutory service, so you have a bit more status. I wouldn't say we're still as respected as I think.
Or authority and recognition, I think, are words that I'm thinking.
I'd definitely say that's right. I think the way you get treated on the wards depends on the people that you're speaking to, their understanding of advocacy, because a lot of people think that you can come across as we get called professional troublemakers, because the staff just want an easy day. They're understaffed, they're stressed, they got loads of stuff going on. They don't want someone who's independent coming in and going, you haven't done that, you know, so-and-so said they wanted to go and do that last week and it hasn't been actioned. Why has that not happened? Or, you know, so-and-so's told me that they've been asking to go out for a cigarette for the last hour, but they haven't been able to because there's no one around. Like, what's going on with that? It can feel like we're sort of checking up on them.
It just made me think, I suppose, these people that are in hospital and in clinics and so forth, going through treatment, they've got obviously, you know, problems physiologically or neurologically, and obviously the symptoms are extreme. You know, they're a lot more obvious to pick up on. But I suppose the people that are working in the hospital, so the support workers, the nurses, the doctors, they're not perfect. It's not like people that are in care are the ones who have got you know, issues behaviourally or neurologically, whatever it may be. But if you're the other side, you know, you have to be that you're all the same. They've all got different personalities. They've all got different temperaments.
Yeah.
You know,
they come from
nurses.
different.
They're working long hours. They come in the next day, and then, you know, you wouldn't have had an issue with them one day, but the next day they're making mistakes. I suppose they've just got minor symptoms. You know, they all show the same traits as the people they're treating.
You get people from different cultures that have different understandings of mental health. You might have some workers who have mental health issues themselves. It's obviously not, there's no law to say that, you know, if you have a diagnosis of a mental health problem that you can't work in mental health. I know
it probably helps.
It does. And same in addiction. When I worked in that field of things for a very short time, a lot of the clients that were coming in were saying, I don't want to work with you unless you've had an addiction problem yourself, because otherwise you don't understand it. Which is a fair enough point. I think in some instances it helps, and I really like that you know, you can not be sort of singled out. You can still work there even if you have a mental health illness. I mean, obviously there's some lines drawn somewhere. I mean, if you're if you're unwell and it's not unheard of for staff at hospitals to actually be sectioned themselves, go to a mental health hospital, spend a little bit of time in a mental health hospital under section, and then come back to work. That has happened.
Really?
Yeah.
Yeah, well, I suppose that's good, the fact that they were able to go back into the work they were doing before.
Yeah.
And they're not being treated any different, ostracised because of the subject of mental health. But you mentioned the drug and alcohol side of things, because that was something we spoke about before we started recording, wasn't it? So I think you came from a salesy financial services background, which was...
Yeah, through no choice of my own. It's just sort of the work that I fell into coming out of college.
Sales, finance,
I did debt collection, I did mortgage sales, and just hated every minute of every career that I had up until sort of the change, really.
But you wanted to work in... Well, you told me charity, but I think because when someone said I want to work in charity, instantly I think of clipboard, and I think of monthly direct debits, and I didn't think of charity in a much broader sense. But I suppose now you probably wouldn't use charity to describe, I suppose, healthcare, mental healthcare. Is that?
Yeah, I mean, at the time, that's not really what I knew I wanted to do. I mean, I really didn't know what I wanted to do. I just knew that I wanted to work in the charity sector. I wanted to have a job that was meaningful. I wanted to have a job where I felt like I was making at least a little bit of a difference somewhere. As to actually what field I wanted to work in, I had absolutely no idea. I didn't know whether I wanted to work with animals, whether I wanted to do domestic abuse. I had absolutely no idea what I wanted to do. So I started volunteering, doing some volunteering for victim support.
That's what you start? That was your very first...
Yeah, well, I thought...
your first step into mental health care.
Because otherwise I had absolutely no experience, qualifications, anything to offer for me to be able to get a job in something like that. So I just had a look at some sort of local places that I could do volunteering. I found victim support, who the police work really closely with them. So if you've had a crime committed against you that's been reported to the police, they offer if you want to be referred to victim support, and it is just emotional support and some practical support as well. So for instance, if you've had your home burgled, then you would get, if you wanted to, referred to victim support, you would get some sort of emotional support. You could talk to them on the phone, or you could have meetings with them just to chat about how you feel, how it's affected you. But then you might get practical support, i.e. do you want some alarms for your house? What can you do to keep yourself safe? So it was that kind of thing. So I did
was that voluntary or was that paid?
Yeah, voluntary.
That was voluntary.
Yeah. So I did that for a little while, and before I started looking for some actual jobs, paid jobs, and again, I was just looking for jobs. I really didn't know what I wanted to do, and then I found the job working in drug and alcohol rehabilitation, and I just thought, sounds fairly interesting, and just had a look into it and somehow managed to bag myself the job. Yeah,
and that was... we won't mention where or the name of the organisation, because I don't feel it's not an attack, because I think we both agree that the fact that these places are there, they are places where people can go if they have got an issue with substance abuse of whatever sort. So they are doing an awful lot of good work. But as we've discussed, and as I know, there is a lot of room for improvement, because you felt quite frustrated at times. Your hands were tied, your thoughts were tied. You couldn't necessarily make any recommendations or suggestions, that it was very much scripted what you had to do, and it was sometimes you knew that what you were having to say or having to do wasn't necessarily the best course of action that you could be taking.
Absolutely,
you knew there was something that you could be doing that would provide better results, but you were actually compelled to use the script. to speak.
Yeah, it's funded by the local government. You have to go by government guidelines. So you know, it was a very.
So is it more? Well, we'll go on to that in a minute, but just talk. What is a drug and alcohol rehabilitation? Was he? I say officer. Is that right?
I'm trying to think what my official title was. It was like a recovery facilitator, I think it was called.
Yeah, for drug and alcohol rehabilitation.
Yeah.
So it's drug and alcohol, basically.
Yeah, substance misuse, yeah. So it wasn't an inpatient place. It wasn't like somewhere where you could go, like a rehab, as it's called. Though you don't stay there. It wasn't an inpatient setting. It was, I guess, what you'd call like a day centre. So... people would come there for one-to-one sessions where you'd sit with someone like me. You would initially have an assessment, which is just you. One thing that I hated was you would get given this pack initial assessment that was just paperwork, and you had to get through all of that, and you had to ask questions about, you know. It did some essential stuff for you to know, but you know, like, can you pinpoint in your life where you started using drugs and alcohol? Did something happen to you that was a clear indicator of where things started to happen? And then just essential stuff like if they're injecting, you need to know a lot about that, because you need to obviously know what the dangers are if they're injecting into certain parts of their body. Are they using clean needles? You need to know all that kind of stuff. So yeah, you'd sit and have the and then that would be followed up with one-to-one chats about how you're getting on, and you provide them with things like drug diaries or drink diaries where they could keep tabs, much like you would if you were on a diet. You'd keep tabs of your diet and exercise. It was like drink or drugs, you know. That enables you to figure out if there's like a particular trigger. Well, it's always when I see my mum and I argue with my mum that I go and have a binge. But a lot of the time it's not that obvious for people. It's not as obvious as I had a bad conversation with my mum, I went out and drank a bottle of vodka.
It could be a thought they had on a Thursday afternoon, which previously it was on a Tuesday morning. They had a completely different thought. Maybe. And
it might not be as conscious as that, you know. It might be completely subconscious. So they might not be able to pinpoint it, you know. Or you'd get a lot of people that would say, I honestly don't know what it is. My childhood was fine. My parents are not divorced. You know, we didn't live in poverty. I was never abused. I did well in school. I've got a good job now. I'm married. I've got this, that and the other. And they might say to you, honestly, I can't tell you what it is as to why I use drink and drugs. So maybe they just have no idea. And then in other times it's very clear why they use drink and drugs. It was a very sort of... a very clear point in their life where something happened to them, and then that's when it all sort of started. So yeah, sorry, I went off track a little bit there. So we provide that one-to-one support. We did groups, so a lot of the people that were coming there perhaps lacked...
Are these people self-referred, or are they recommended, or they're...
A number of things, yeah. You could self-refer. A lot of it was self-referrals. You might get referred by your GP, by hospital if you get picked up and brought into hospital because you're really drunk or whatever. They might refer you somewhere like here, or loads of different organisations. You could find your way to us fairly easily just by looking us up on the internet or whatever. So yeah, that we did the groups. So that's stuff like self-motivation, self-esteem, sort of challenging different behaviours. Even just, like, sometimes we do things like cooking groups. A lot of the people that were coming to us didn't have basic skills, you know, like, again, talking about that spectrum, you might have someone who's got, from the outside, what seems like a really put-together life, and they've got a wife and kids and a nice house and a job and this, that and the other, and they're functioning, as it were. And then you might have the other end of the scale, people who are... you know, homeless, who perhaps didn't have a very good education.
Hello, mate.
You want to get on the camera too?
It's the Overactive cat.
Yeah.
The Overactive cat, my sponsor, my mascot sponsor. I don't think I'll sponsor him, the little bastard. Doesn't work. Right.
So you get varying different people. So it's about sort of making sure that they've got the basic skills to battle, you know, the stuff that they've got going on in their lives. So there was that group stuff. And then there was just things like a needle exchange. So for people who are injecting, you know, you can't expect them to stop injecting overnight. Nothing you're going to do sort of in the space of a couple of weeks is going to stop someone injecting. So it's just about harm minimisation. So making sure they're using clean needles.
So you had those on site?
Yeah, they could come. It's free. They could bring in their old needle.
Okay, we're back for part 2 of episode 2 of the Overactive Brain.
Yeah.
We'll have him put down tomorrow. I'm only joking. Right.
Yeah, so I was saying, it's about harm minimisation. So if someone's not going to stop injecting, if they're not gonna stop doing drugs, then it's just about doing it safely. So cleaning the skin before you inject, so you're not pushing all the stuff that's on your skin into your bloodstream. How are you injecting? You're doing it safely, not doing it in high risk areas. Just using clean materials. Just getting a bit of awareness, because a lot of people didn't, surprisingly enough, people who are using drugs actually just a lot of the time didn't really know what they were doing.
No,
so,
I guess that even there will still be some people who are extremely conservative saying, I can't believe that you're doing that. I know that there are opinions out there saying, well, I don't know why you're helping them, don't know why you're making things easier for them. And I'm sure even if you sat down with some people and explained, we might as well make something that's happening and we can't stop, cleaner, safer, you won't persuade everybody as to the logic behind it. I think the mass population will certainly agree with.
Yeah, well, there's I can't remember which countries it was. I think it was in like Scandinavian countries or that sort of part of the world where they actually set up like safe injecting booths.
Wasn't that in Switzerland?
Yeah, it might have been. Yeah,
Switzerland and Portugal.
Yeah. So they've actually got a place where you can go, and it's supposed to be safe and you can sort of inject there in peace, basically, which, I mean, when the idea first came out, I think was kind of like huge uproar, but I have no idea what the facts and figures are, but the sort of drug-related deaths and things like hepatitis and AIDS,
which
and
saves
bloodborne,
their National Health Service, or it would save our it must save our National Health Service an awful lot of money, because I'm sure providing a clean needle is cheaper than treating somebody for a severe infection. Yeah,
absolutely. Yeah, because when you think about people dying because they've been injecting drugs, I mean, the amount of times that it's actually the drugs that kills them is very small. It's the other things that come from that. People are losing limbs because they're not injecting properly, and their veins are collapsing, and they're catching bloodborne viruses and
well, you've mentioned you've seen some quite awful things, haven't you? Things that I didn't even think existed, or even possible, even to someone who's so heavily addicted to drugs, but people were injecting into their eyeballs.
You get loads of stuff like that. I mean, people, the high risk areas of like the neck and the groin and things like that, but people will inject pretty much anywhere that they can, and when their veins collapse and they can't inject in their veins anymore, they'll turn to eyeballs, private parts, tongues, and there's different types of injecting as well. So obviously with things like heroin, you get IV, intravenous, which is what people think of, the sort of classic train spotting sort of in the this bit of the arm here. But then you've got intramuscular, which is mainly what people who are steroid users would do. But then you've also got, I don't know if I'm going to get this right, subcutaneous, which is under the skin. So it's called skin popping.
I'm sure my viewers will pick you up on that.
I'm sure they will,
yeah.
It's called skin popping, so it's just under the skin, which is less effective. But people will just basically, they just do anything they can to get it inside of them, which is...
So that's a really good, I mean, that is an essential service that they provide.
Absolutely, yeah.
And are there lots of these companies? So are they? They're available to most people in most places. It's not most
sort of biggish towns will have one commissioned service. So they have to sort of like bid for the patch kind of thing. So if you're the one particular company is there, and they have like a 3-year sort of tender, and then that finishes, and all the sort of local companies have to sort of bid and say what they're going to do, what they're going to offer, how they're going to keep their costs down, and whichever is the most successful gets picked, and they might have that tender for 3 years, and then it gets reviewed. It might be sort of...
Is there any just making me think about, who's going to keep their costs down? Because sometimes keeping your costs down is what exacerbates a problem sometimes.
Oh, massively. That was a big part of the problem.
It's the direction of where funds are going. It's not so much how much money we're raising, but where it's being spent, or what our outgoings are, but what are those outgoings being spent on? But was you ever measured on performance? We had 100 patients and 20 of them have been clean for a sick period of 6 months or more. How could you measure what difference you were making to anybody who walked through your door? You'll know, you'll have a feeling, you'll see people, you'll know whether they're the same or they're getting worse or better, but is there any way of actually measuring this analytically, numerically, quantitatively?
It was very wishy-washy. I mean, yeah, there were targets, absolutely.
There were? Oh.
Yeah. But a lot of it is, again, it's just tick boxes, a lot of it was to do with your paperwork. So someone would have to have some sort of like care plan or risk management plan, all these kind of different plans, and they had to be reviewed every 6 weeks or whatever. So if you would have your client load of say 30 or 40 clients, and it would pop up on your system and say if you had paperwork outstanding. So that was an indicator, is make sure that you're seeing your clients regularly, that you're going through these reviews regularly. But unfortunately there was just so much paperwork and so many reviews and plans and this and that you just lose sight of actually... You could never just sit down with your client and talk to them about what's going on with them without having to be writing on bits of paper and, oh, hang on a minute, no, sorry, I've got to do this plan before we move on to the next bit. It was
which makes it more clinical and less personal.
It was very much so. And it makes you dread it, because I've got to see so-and-so because I've got to do a care plan with them. It's not about I've got to see so-and-so because last time I saw them they were in a really bad place and I want to check if they're all right, or they were doing really well and I want to see if they're still doing well. It wasn't that. It was I've got to get this bit of paper done, or I've got to do this, so that was the first thing. And then, but the company as a whole you do keep tabs on how many sort of successful clients you have that are discharged from the service. But it's very difficult to monitor what is successful, again.
Because they, maybe I should let you continue, but just the first thing that came to mind is you may have treated someone and it may have been successful, but they may have relapsed 6 months later, but they don't come back to tell you. They might go to a different service, or they might move town. So there's no way of, you can't keep track of everyone who leaves.
And that's a huge thing with addiction, is that a lot of people who have addiction problems will manage to stop at some point in their life, but how long for? If they haven't done the necessary work in looking at what is causing them to use the drink and drugs. And sometimes that is not a simple task, that is a monumental task. If they are just focusing on quitting the drink or quitting the drugs and not looking at why they're using them in the first place.
The real causes.
Yeah. And again, it's like diets. I keep relating it back to that because I find that that's quite a relatable thing for everyday people. Is that you might go on a diet and you manage a week, 2 weeks, a month, a year, a period of time, but eventually things happen and you sort of creep back to your old behaviours.
You'll start buying white bread instead of brown bread, or you'll have 3 sausages in a sandwich instead of 2, or you stop buying Weight Watchers own, you'll buy the butcher's sausages, which are a little bit tastier.
Going back to what I was saying about mental health, is that when you get better, you think, okay, I'm better now. And so you stop taking your medication, you stop going to the counselling. And I guess for some people who have addiction problems, it's like, okay, I used to be an alcoholic 2 years ago, I've beaten that now, so I've got a party on Friday night, so I'm just going to go and test the water and I'm going to go and have a couple of drinks. And that goes fine, and there's no problem. and then a couple of weeks later there's something else, and they go, well, I did it last time, and then but slowly it starts to spiral out of control again, or
a traumatic event happens, and their body just turns to the best immediate
it's their coping mechanism, isn't it? It's for a lot of people, it's the only coping mechanism that they've ever known.
I guess one of the most effective coping mechanisms in terms of its instantaneous ability to help you forget things.
Absolutely, yeah. I think we talked about this before, but Johann Hari in his book.
I have his book somewhere.
I think it's over there actually. So he's got Chasing the Scream, which is specifically about addiction, but his book Lost Connections, which is about brilliant book about the causes of anxiety and depression. He actually mentions in there, and I'm not going to get the wording right, but he says something about addiction is people find it so difficult to be inside their own head that's when addiction occurs, because it takes them out of their mind, so to speak. I'm completely misquoting him here, but basically it's too difficult to be present in your own mind, so you have to find an escape, and that is how people do it. And maybe originally they were using it as an escape because their dad died when they were 7 years old, and it was a really traumatic time for them. But as an adult, maybe they lose their job, but the only coping mechanism they know for pain is drink or drugs, and so they're going to turn to it for that as well. So yeah, you could.
Most people do it on a very minor basis, but when you've had a really bad day at work, you come home and then you just say, let's go down the pub, or you open up a bottle of wine, or you come out of a meeting and you light a cigarette and then have a second one straight afterwards, because it has this, this relief effect.
Absolutely, yeah. And you see it on the TV. You've got this this sort of like a picture of like a stressed housewife sort of pouring out like a bottle of gin and taking a few glugs of it. You see it a lot in the media and things like that. It's used. It's a stress relief. It's a way to enjoy yourself. And I mean, alcohol in particular, which I think is, most people who work in that field will tell you is one of the most dangerous out of any drugs or anything that you can get, because it's legal, it's so socially acceptable, it's fashionable, and you can get it anywhere,
and it's cheap,
yeah. Or perhaps appeals to one side of the scale, but now, I mean, especially when you think of like this big gin explosion that's happened now, and you've got all the really fancy bottles and the different flavours, or you get whiskey connoisseurs and wine connoisseurs. Yeah, absolutely. Yeah. And you just think, but if alcohol didn't have that effect on people, the sort of the relaxing and the numbing of certain things, then it obviously wouldn't be anywhere near as popular. People are not necessarily into it because of the different flavours and the packaging and the this and the that. If it didn't have that effect, then
reduces inhibitions.
Yeah, absolutely.
And allows you to do things and feel more confident in certain situations.
Yeah. I mean, Alan Carr talks about it in his book. Not Alan Carr, TV presenter.
I think Alan Carr, who wrote
The Easy Way.
Yeah, he did The Easy Way to stop smoking, and it's been interpreted into drinking and many other.
Yeah, he's got loads of different things, but I don't necessarily agree with everything that he says in his book, and whether it sort of, I mean, it probably works for some people, but he made a point of, if alcohol didn't have that effect on you, would you still drink it? Would you still? I mean, personally, I've had non-alcoholic wine before, and I know it's not the same, but I think it's horrible.
Yeah, but that's the taste. I think if you could drink a bottle of wine and it still has that same taste, that same sharp, strong, bitter flavour to it, which the non-alcoholic stuff does, but with zero effect on you whatsoever. So if grape juice tasted exactly the same, would you still drink it? Well, obviously not. Because I think because I've also read that book as well. You don't go into a pub and go up to the bar and say, I'll have a pint of water, please, and then drink that, and then 20 minutes later go and have another pint of water, and then 20 minutes after that go and get another pint of water. There's only so much water that you can drink. It doesn't matter how, I mean, I love apple juice, I love Oasis, I love Red Bull, but I don't sit there and drink pint after pint after pint after pint on a Friday night. despite the fact that I enjoy it thoroughly. It serves a purpose, which is to quench my thirst.
Yeah, absolutely. And that's the thing about alcohol, is as you're drinking it, it's dehydrating you more, which is making you more thirsty, and is therefore you feel like you need to drink more, and it's just this sort of cycle.
That phrase, you drink 1 pint, you wee two. Yeah. But going back to the drug and alcohol rehabilitation role that you were doing, what did you feel? Because you became a little bit, I don't want to use the word disillusioned, but you ended up leaving there.
I would use that word.
You really would use the word disillusioned.
Yeah. I mean, it what they were doing wasn't working in a broad sense. I mean, yeah, it did work for some people, but you had people who had been in the system for, I mean, in some cases, like longer than I'd been alive. I mean, I know I'm not old, but, and you would just, so another thing they did, which I hadn't mentioned yet, was we prescribed things. So not me personally, because I can't prescribe, but so there's heroin substitutes.
Diamorphine? No, diamorphine is heroin. Isn't it the scientific name?
Yeah.
For
heroin. That's painkillers, morphine. Yeah. So it's hang on, I've got to get this right because I haven't done it in methadone. That's
methadone,
it. Yeah, not to be confused with methadone, which is MCAT. Yeah, methadone. And another one, which name I can't remember, but so basically heroin substitutes. So again, it's that kind of that thought process of, well, you're not going to get them to stop taking drugs. If they do, to stop taking heroin, they'll go into some pretty nasty withdrawals. In terms of how dangerous that actually is to someone, heroin withdrawals, it's nowhere near as dangerous as alcohol withdrawals and some other stuff. But so if you're not going to stop them doing it, then it's about how can you make it safer for them. So by actually prescribing them medication, they know what's in that, because obviously when you're buying heroin off the street, could be cut with anything you don't know, and there's all sorts of stuff that can be in there that's really, really dangerous. Obviously you want to stop them injecting, because even if they're injecting safely, it's still obviously not a good thing to be doing. So you prescribe that, and the idea was that they would start on a low dose and that they would titrate up to something that would keep them stable, so they're not getting any kind of
so they'd be weaned onto it rather than go onto so they start on a low dose always.
Right, always. Okay. Because it's you obviously can't just whack them on a great big dose. Even if they come to you and say, I'm using loads of heroin every day, there's no proof of that, and you don't know what type of quality the heroin is.
Very good point.
So you can't just whack them with a great big dose, because if they overdose, then that's obviously not great on you. So yeah, you put them on a small dose, titrate it up.
So where is this stuff kept?
Where is it kept?
Yeah, where do they get? Where is it prescribed from? Where is it?
So they go to the chemist.
Oh, so it has to be from
from a chemist.
Collected from the chemist.
Yeah.
Wow, I didn't know that you could get a heroin substitute from just a high street chemist.
Yeah.
So there's people that might go and collect this this substance from Tesco's supermarket. Really?
Yeah.
Right, I didn't know that.
And methadone is a bright green liquid, so it's quite
obvious.
If you know what it is quite obvious.
I should imagine they put it in an opaque bottle, maybe, when they get
there's so on the prescriptions you would have, there's different types. So there would be a lot where it had to be supervised. So if someone was known for, because then there would be people who, I can't for the life of me remember what the oral tablets are, because it's not always methadone, but you would have people that would pretend to take it and hide it when the chemist wasn't looking, or even put it in.
So you have to take it in front of the chemist. What, the tablet?
Yeah, or the methadone, or the liquid.
How does the chemist know that? So if you are, I'm just imagining myself. I'm queuing up at the chemist at Tesco's because I need whatever. I've got an infection somewhere, and someone in front of me is one of these individuals. They have to make that. They have to take it there in front of the chemist.
Potentially, it depends. So we as a team and the doctor that's prescribing with us, depending on the person, knowing them, we might put on there that it needed to be supervised. So if they were known for not taking it and selling it on, or if they were known for that kind of thing, you would put on there that it needs to be supervised.
I suppose then your trust is on the chemist to do that, because I suppose it just reminds me of, make sure you're in because your package needs to be signed for. You know, they're absolutely adamant, the phone company do not want anyone else to receive that phone but you. But the amount of times that iPhone has been handed to the receptionist or a colleague,
it did happen. It did happen. But people were just
important.
really good.
It's more important than somebody signing for my mobile phone, because a mobile phone is easily replaced. But
people, you'd be surprised about, you know, people putting it in their mouth and then spitting it back out and selling it on. You would hear about it a lot.
Yeah, of course you would.
So that was another thing that we did was prescribing that for people. But originally why I was talking that in the first place is that, so the idea is that you put on the low dose, you're titrated up, you're kept stable for a period of time, and then you're reduced off it. But the amount of times that would never happen.
Reduced down to 0.
Yeah.
So you're cutting down to 18 cigarettes to 16 cigarettes. Exactly.
Yeah, that's the idea behind it.
Never cold turkey.
Yeah, never cold turkey, because it's just such a horrendous experience, because you've got obviously all the withdrawals. Like I said, heroin withdrawal is, in terms of a lot of other things, it's not particularly dangerous as in dying from it, but it's still incredibly...
emotionally significant.
So, and I mean, it's so horrible that if you were in withdrawals, it would be very easy for anyone to say, fuck this, basically, I'm not doing this anymore, and they would just go out and get some heroin. So, so they would take them off it slowly. But again, there was just...
Whose responsibility was that? What did that look like? What does the reducing people's consumption
So it was like, so me as a recovery facilitator to make a plan with that person and sit down and talk to them about it. Have you had any kind of cravings? Are you getting any kind of withdrawals or uncomfortable feelings? And you would rely on them being honest with you and saying yes or no, and then you would make a plan, and you know, they'd come into the clinic, see you and the doctor, so you'd sit alongside a doctor, and you would sort of talk about, do you think you're ready to go down? You know, come down a few points this week. But people were just so reluctant to do that, because
the people in care, the people
the
receiving
clients,
it.
Because,
and can you make them? I mean, was there a structure? Said, right, okay, well, 6 months, and then we're going to start bringing you down.
Yeah, that's what we would do. Yeah.
So what was preventing that from happening?
Because they would sabotage it in some way by, they would say, a lot of people would use on top of their prescription. So even though they were getting this certain amount, that they would. So I'm losing my memory on this, but there were 2 different types. So there's the methadone and whatever the other one is, which I can't remember. One of them you could use on top of, and one of them you can't. So the one that you can use on top of...
I mean, as well as real heroin.
As well as real heroin, yeah. But then there's another one where if you use on top of it, it just doesn't really work. So people were very reluctant to go for that one. They would want the one that they could use on top of. And so if you've got this plan in place and they know that they're coming to see you in 2 weeks' time, and at that point you want them to drop down a dose, but they come into you and say, I've had a really bad couple of weeks I've been using on top of my prescription, then you're not going to drop them down, because not only are they going to have that drop down in medication, but then they're also going to have the withdrawals from the heroin, and it's not going to work. So things like that would happen quite a lot. So they would sort of sabotage it, but people would they didn't want to come off it, because it's you know, they're addicted to it, for starters.
You're taking away the thing that's giving them the most relief at the present time.
And in a lot of circumstances, they were getting it for free or very cheap compared to normal drugs. It's a reliable source, so they haven't got to go around finding dealers, finding the money for it. You know, it's just a constant income, and all they've got to do is turn up at our place every 2 weeks, turn up for an appointment.
I suppose in a way that's a good thing. You don't want people going out committing burglary, committing crimes to fund. You don't want money ending up in the back pocket of someone who isn't. I'm sure many people would argue they don't want pharmaceutical companies to continue riding off the back of people's physical, mental. Not that I'm absolutely saying that what they're doing isn't absolutely necessary, but I think that for obvious reasons people would rather that it would be done under
the trouble
a
is that
environment.
They were on these prescriptions for years and years and years and years and years, and
and you didn't feel that there was much progress being made. It was just you're almost contributing really to the sustained problems that they have in an indirect way, in a non-malicious way. What restraints were there that you felt? What was holding that company back, or maybe every other company that probably experiences?
Again, funding and staffing. I mean, you would have, like I said, about 30 to 40 clients on your caseload, and you would need to see them roughly once every 2 weeks. So, you'd have to keep seeing them pretty regularly.
Bring your mic down a little bit, just to just pull it down. That's it.
Yeah.
Yeah.
You'd have to keep seeing them pretty regularly, but you just wouldn't have enough time. You might have a half-hour slot with them, and in terms of training, I, as a recovery facilitator, got barely any training. I mean, you'd get some training on the basic things. Like stuff you need to know, sort of like bloodborne viruses, say for injecting. But in terms of actually dealing with people,
ongoing skills that you think would have been helpful. Yeah,
and I mean, really, in my opinion, what a lot of people in that situation need is real help in terms of psychology, counselling, therapy, all those kind of avenues. I mean, they were just coming to us. We were sitting down for half an hour, having a chat about how they're doing. And a lot of the people there, it was, someone would come in and say, oh, I haven't had a very good week. I've been using or I've been drinking. I mean, we didn't have the skills to deal with that. It was just really, you shouldn't be doing that. We've talked about what the dangers are when you do that. Why do you think it happened? They might not be able to tell you. And it was just a bit frustrating. It just felt like we weren't getting anywhere with it. And then it would just be, you'd have the next client coming in, or you'd have to go and do a group, or you'd have to, there would be a clinic running, which you'd have to go and facilitate. So you just never got the time to actually get to know people and sit and think about what you could do to help them, what they needed as an individual.
So do you feel that if they had have invested more time and given you really significant professional training, that you still may not have had the capacity to be able to use those new skills because of the amount of paperwork and everything else that was involved?
There was just so much paperwork. I feel like it was just so impersonal. And some of the questions that you would have to ask, I mean, I won't say what some of them are because it might identify who the company is, but you were told to ask these questions and you just think these are just so pointless. I just don't understand what I'm gaining out of this. It was really, really difficult not having much training at all and having to deal with a really difficult group of people. And I felt like I was letting them down, and I felt like there was nothing I could do about it. So, I would say I became disillusioned with it all, to be honest.
Yeah.
Yeah.
Well, thank you for making episode 2 quite a good chat. I enjoyed that, and I've learned a little bit more about what you do. And hopefully people that are watching this will get something out of it too. There's an awful lot about the mental health mental health industry as a whole that people don't understand. And whilst I think that the general public's attitudes towards it and stereotypes of mental health addiction, depression have improved significantly, I still think it's got an awful long way to go.
Oh, it's got a huge way to go, absolutely. The way people view mental health, addiction, all that kind of stuff, things need to change massively. Not just the general public, the NHS, the people that work in the NHS, the patients. Everyone has a lot of learning to do about mental health and addiction, massively. And I think a lot of the things that we've thought up until now are untrue. And
we're making progress. I do sense that there is progress being made, and we'd all like progress to be moving along a lot faster in every single field, but I think you're always going to find...
I think mental health is coming along a lot better than addiction is. I think addiction is something that people just don't understand. People just cannot get their heads around.
It's still taboo. It's still regarded as
a choice. People still see it as a choice. People still see it as that person being selfish, and just not understanding what addiction is and how powerful it is. I think that's the big mistake.
Yeah, well, maybe that'll be a subject that we can talk about on our next podcast, whatever this is. Yeah. Thank you, Biddy. Thank you, Matthew, for joining us.
Thank you, Truffles.
Yeah, thanks for your contribution. All right. See you guys later.